Hello, this is Siddharth Tambar from Chicago Arthritis and Regenerative Medicine. Something I want to talk about today is how do I, as a physician, make decisions when it comes to employing regenerative medicine treatments for my patients and in my practice. So this comes up because there's a couple of bigger picture things going on in the field that are impacting how we're making decisions. So the Canadian Health Regulatory Agency recently came out with a decision to essentially ban the use of stem cells in the practice of medicine, and that includes in musculoskeletal care and in orthopedic care. There's a lot involved in that. But it brings me to a blog post that Dr. Crescentino from Regenerative published recently regarding how physicians look at medical literature in the use of regenerative medicine. And he quickly looked at around 100 physicians or so and found that the majority of physicians look at medical literature that includes case series of patients or comparative trials, and then utilizes that to make decisions in terms of what makes sense for their patients when it comes to regenerative medicine. That's different than what some circles think is the level that should be utilized before making a decision on what sort of care to utilize. Ideally, we'd be utilizing placebo-controlled, randomized clinical trials for everything, which means you'd be looking at here's one treatment and here's another treatment that is inert or placebo. The physician doesn't know what's being given, the patients don't know what's being given, and then see what happens, and then make a decision. The reality is that the vast majority of medical treatments are not based on those kind of studies. They're based on a collection of evidence that builds up over time, that builds up over an incremental approach, looking at what's worked in patients, what are safety potential issues, comparing it to other potential treatments that are standard of care, and then incrementally physicians deciding what is correct or what's not correct. There's a lot of value to that approach, and I'll talk about why I think the following 4 steps fit in with that kind of approach, and are what I think any physician, including myself, should utilize when it comes to deciding what sort of regenerative medicine treatments are appropriate for their patients. The 4 things that I think are critical are, number 1, what makes medical and scientific biologic sense. Number 2, what does the available medical literature say? And number 3, what is my own clinical experience? And number 4, what would I do for my own family members and friends? So number 1, it has to make clinical and scientific sense. If something doesn't work within the clinical paradigm that you believe in, you really have to rethink things. So as an example, we know that steroids can weaken tissue. So if you have an Achilles tendinitis, you really should be wary about getting a steroid injection into the Achilles tendon. It can potentially weaken the tissue and lead to a tendon rupture. I would never recommend that as a treatment for a patient. I think there's other options that make a lot more biologic sense. On the other hand, if you can utilize some of the regenerative medicine treatments that are available, they work upon a understanding of how the body normally repairs and heals itself, and utilizing products that help to recuperate from an injury, utilizing those biologic principles. That makes sense. Number 2, what is the available medical literature out there? So does everything need to be the highest placebo-controlled, randomized controlled trial? Again, that would be great in an ideal world. The reality is that is not how the vast majority of medicine has been built upon, or certainly not in orthopedic and musculoskeletal care. It's built upon looking at what works clinically in patients, how does it compare to standard of care, what are the safety issues, and then deciding what's appropriate. That's really different than how things are described in the academic literature. And unfortunately, some of the decisions that regulatory bodies are making their decisions based on are not how physicians really practice or apply clinical principles on, which is an incremental approach that looks at what works, what doesn't work, and then progressively making decisions. Number 3, what actually works in your own clinical practice and patients? That's important because over time you start to realize certain patients are better fits for certain treatments, and there's certain patients that maybe are not appropriate. You need to synthesize that with what you're seeing in the medical literature as well and what you're hearing from other colleagues. Lastly, possibly gold standard is what would I do for my own family members and friends? If a treatment, no matter what the evidence is not good enough for me to use for my own parents, wife, or daughter, I would never utilize that on my own patients. To me, that combines and synthesizes everything else. What makes medical sense? What makes biologic sense? What does the literature say? What does my own experience say when it comes to how I treat my own family? If something doesn't meet that threshold for treating my own family, I wouldn't apply that to patients. Absolutely not. I think that's the right way for physicians to think about how we incrementally push this field forward. Ideally, physicians, we would be self-regulating and self-checking physicians who are not approaching regenerative medicine in that same manner. Unfortunately, not enough of that has happened, and because of that, the regulatory bodies are starting to step in to help regulate. And unfortunately, they're not utilizing the same approach that physicians have historically utilized to incrementally advance the field of medicine. But that is a big picture approach of how I, as a physician, and how physicians have traditionally approached patient care and how to add newer treatments to their patient care. Love to hear your thoughts. Thank you for your time. Be well and have a good day.